it's one of the most surprising things that I saw when I was reading about encephalitis, especially the NAD, what is
NMDA. It's a
NMDA,
mouthful.
especially
N-methyl
the
D-aspartate receptor. It's the name
yeah,
of the receptor that the immune system's
the
attacking.
anti-NMDA encephalitis is the psychiatric symptoms. I'm so fascinated by that because, in my mind, I often think about how, we think about emotions, for example, and these are all just hormones. Our bodies are processing hormones, right? And then inflammation happens and you're getting these kind of psychiatric manifestations. My first thought is that encephalitis seems to be at the very extreme end of the spectrum of some sort of inflammation event that could lead to psychiatric manifestations. Do you have any thoughts, or is there any conversation about how that might cascade differently but still manifest as maybe psychiatric things? Because I know there are some papers that came out about how the brain has its own microbiome, right? I think about things like allergies, right? Some people have chronic rhinitis and some people don't, and they live in the same house, so our bodies react so differently, and we have these kind of biomes. I want to see are there any dots to connect when it comes to psychiatric manifestations and autoimmune issues?
Oh my goodness. That question is really, really getting to the core, right? There's so much work to be done here. Um, you know, there are different flavors of autoimmune encephalitis. And to your point, one of the closest mimics of NMDA receptor encephalitis that's often considered when you're working someone up for that diagnosis is schizophrenia, right? And so when we work in this field, when we take care of patients with autoimmune encephalitis, we're confronted with every visit, with every patient interaction, with these overlapping questions of what part of this is the immune system, what part of this is your genetics, what part of this is some exposure, and why did you, in this moment, get autoimmune encephalitis? Now, for NMDA receptor encephalitis, for about half of the patients, we have an answer because they, especially the young females, but even occasionally males, have an associated germ cell tumor. So most commonly, the young females will have what's called an ovarian teratoma. Some people call it an ovarian dermoid cyst. And that's what we call germ cell tumor, not germ meaning an infection, but meaning a cell that can develop in any number of different directions to become different tissues in the body. And you would expect that in an ovary, right? Because that could become a fetus, right? So about half of the young women have this teratoma. And so what happens is the immune system's gaining access to the inside of that mass. And within that tumor are cells that are basically differentiating to neural tissue and have NMDA receptors on them. And so you can imagine the immune system is not necessarily so discrete to be able to appropriately attack the ovary and not attack that exact same receptor in the brain. So that's what's going on in half of the young women. But for, the other patients with NMDA receptor encephalitis, the other half, we don't find a tumor. We don't find that sort of, clear connection. Sometimes there's a story of a prodrome, we call it, like a viral prodrome, or a question of other triggers, right? This is where the human mind goes immediately. When something happens to us, we trace back to, what did I do yesterday? What did I do last week that could have caused this? And that's still wide open. Do these people have an infection? Did something happen? Did they encounter something in their environment? And it was that right sort of coalescence of your immune system in that moment on your genetic background, and wham, you end up with this inflammation, this very dramatic inflammation. We don't know the answers to so much of what you're asking. And the other aspect of what you're talking about, the link to what we consider psychiatric disease, if you will, right? It's so artificial what we do in medicine. We have to categorize in a way in order to get to a discrete level, a diagnosis, so that we can direct treatments and interventions, right? But to separate half the brain into neurologic and the other half into psychiatric is really preposterous, right? But in some ways it feels like that at the dogmatic level. But NMDA receptor encephalitis, some of the other autoimmune encephalitides are the perfect example of the fact that that's not how the biology works, and that one receptor can control many things and can manifest in many ways. So many of the patients get behavioral symptoms, but they also can get seizures. They can get sort of the full spectrum. They can get posturing movements that we consider, movement disorders in the neurology vernacular. So many things can happen. And yes, these diseases, I hope in a way, really force us in the medical community to confront the fact that we have to be cognizant of the fact that every individual in front of us is the sum of their parts. They're going to all present differently, even if the exact same thing is going on. And there's a lot of humility in this because we don't understand why it's one way for one person and a different way for another. This is really, when I'm speaking to young people, I say, if you want to answer this question, you got a whole career ahead of you, right? You will never not have a job because it just leads to more and more questions the more we ask. So for NMDA receptor encephalitis specifically, we're fortunate that we have a clear biomarker. So we check the cerebrospinal fluid and we send off testing for NMDA receptors in the spinal fluid. They should not be there unless you have NMDA receptor encephalitis. So that makes it easier on the neurology side. It's much harder when you're making psychiatric diagnoses, when you don't have necessarily a clear biomarker.